Hello, everyone. It's good to be with you all. Today is February 20th, and uh, it's another session of the virtual town hall, Living with Lupus in our community, Living with Lupus and COVID in our community. And as always, I want to thank Terry and everybody at the Lupus Foundation of America, Georgia chapter. Thank you so much for being with us each and every day and for co-sponsoring this event, along with the Georgia Council for Lupus Education and Awareness and the Goals Study at Emory. Please continue to be advised that this is just general information, that you need to take all of this along with other information and take it to your healthcare provider for the best information for you. So the last time we met, and I'm sorry, it's been a few months. We've been through a lot over that time. But the last time we met, it was this map, and it was in December. And here you see where it was back then, and the heat map in terms of new cases and where they are now. Is this. And you get the impression, and the valid impression, that cases are going down locally, and thankfully they are, but I think this is a reminder that globally there's still a lot of areas that have very high case rates, especially in Europe and in Asia and other parts of South America. So we have to keep that in mind. This is what the US looked like in terms of the heat map of new cases in December. And this is what it looked like recently. It doesn't give you a sense that things are necessarily cool. It's cooler than it was a few weeks ago at the height of the Omicron variant surge. But again, it reminds us that there are a lot of cases still in the US, and that is not the impression that you get. And you know, the hype in the news only will go so far if you keep saying day after day that the cases are up, the cases are up. We're living with it better in many ways, and we'll talk about some of those things over time and today. But certainly this map should remind us that there are areas, including our own, and especially our neighbors. If you look at Kentucky, and Tennessee, and Alabama, those have some of the highest rates, or the highest rates in the country, and they're not too far from us. But if you look at the last 90 days, and especially from where we were last time when we met together and where we are now, and everything in between, we went through a very significant surge, higher than, in terms of total number of cases, higher than any that we've had so far, given how amazingly transmissible Omicron has come to be. And thankfully, we are starting to see all the numbers go down in terms of new cases. And in our region, the blue here, it's still one of the higher ones, but actually it's coming down just along with the rest of the country. And this is the broad US as a whole. And you can see, as I pointed out earlier, that the total cases are going down. And thankfully, the patients in the hospital are going down. This is the last 90 days, but still at a pretty high level. The tests that are being done as a result of fewer cases is similarly going down, and the deaths, which remained pretty stable, but always lags behind cases, we're starting to see, at least nationally, they're going down. But the magnitude is just numbing, isn't it? That each and every day still, as of today, there are over 2,000 deaths a day, every single day. And it's hard to really put your head around that, frankly. This is what our state looked like in December, and this is what it looks like recently in the past week. And so, you know, the areas are patchy, but there's still areas within our state, especially in South Georgia, that are very high, in parts of Northwest Georgia as well. But we are starting to mirror what's happening in the rest of the country in terms of the total number of cases in Georgia going down. The tests are starting to go down, as you can see. The hospitalization peak is starting to go down, which is key. The deaths haven't quite ticked down yet for us in Georgia. And you can see the percentages here. Everything is going in the right direction except for the deaths each and every day. You know, we're seeing an increase in deaths. And so we hope to see that, and we should be seeing that starting to trend downward as the case numbers continue to go down. So I'll kick off this next part with a few of the questions that came today regarding the fourth booster, whether it's recommended for people with lupus and what manufacturer would we recommend? Are there any specific criteria? And what are the general recommendations in general? The fourth shot, or if you get the first series of 2, then the first booster, which is the third shot, and then the question here is, when are we ready for the second booster or the fourth shot if you get Moderna or Pfizer? And for everybody who is immunocompromised, and I think there's really no argument that anybody with lupus would qualify in this category if they so choose to be categorized as such, that anybody with lupus is recommended by the CDC to receive a fourth shot. The question that's going around now is actually for the general public, but we've known for several weeks now that that people who are immunocompromised should be considering a fourth shot. And I can tell you that our group here at Emory and at Grady, we generally agree that for most of our patients with lupus and other chronic autoimmune conditions, especially those on immunosuppressing medications, that we're generally recommending the fourth shot or the second booster, and we have been. And this comes with the data that even in the general population, after the third shot or the first booster, that immunity is waned even after a few months, and they're quoting around 3 to 4 months that immunity is waning. But one thing I failed to emphasize in all the starting slides that I had was that the vast majority of the cases, and this holds for practically every wave of different variants, the vast majority of the new cases, the symptomatic cases, the ones especially in the hospital, and the ones unfortunately who are dying are the ones that are unvaccinated. So yes, immunity is waning, and even if you've gotten vaccinated, and you've probably heard a lot of people, your friends, family, coworkers, who've had quote unquote breakthrough infections. And there's a different variety of those too. Some are not so mild, but I think the one thing to remember is that had they not gotten any of those previous vaccines, that their cases would have been probably much more severe. So people who are out there with lupus, especially on immunosuppressive medication, should talk to your doctors about, if you haven't already, getting that second booster or the fourth vaccine shot. Regarding whether it should be the same manufacturer as the original shots before, it doesn't matter. If you did Moderna before, it's fine to do Moderna again or switch to Pfizer and vice versa. And you just need to go and say that you're wanting your second booster because you're immunocompromised, and you should not have any problems with that. There have been some news about whether this new Omicron variant is starting to shed off into other subvariants. And some of you may have heard about this other subvariant, the BA2 subvariant, that is not only more transmissible, but there's a question of whether it could cause more severe disease. And at least when a smaller study that has not yet been peer reviewed, but was reported on a public server as, at least in hamster models, that the hamsters infected with this new Omicron subvariant that is not the predominant variant of Omicron, but it's around like 1 or 2% in the US, the last that I saw, seems to have gotten the hamsters sicker. But something that I just read on the news that I haven't really found on the actually published yet is that there apparently is a study in Europe that that seems to indicate that this new subvariant is not as severe. So we're going to keep hearing about conflicting evidence as more information comes about, and that's par for the course when these things occur. But the point really is, and this is why the scientists and the government officials always seem to be sort of hedging and not definitively saying, even with all the optimistic trends in the curves, that things are over. You don't want to be caught if you're in that position when you're making such a dramatic impact on so many people of overstating things. And viruses are very tricky, and you just never know when something will come about. Omicron came out of probably southern parts of Africa, probably out of somebody with HIV, where there was immunosuppression. It allowed a chronic infection, a lot of turnover of the virus, and that increases a chance of new variants coming out of that. And that doesn't mean that it couldn't happen again. It may not happen again, but it could happen again. There's just absolutely no way to know what kind of variant, what characteristics it will have, how it'll react to the vaccine. So that's why we just can't make definitive statements medically and scientifically in the next few months. But we do know that generally over time, these things will settle. We just don't know how quickly. I mean, we have experience with pandemics. We've had pandemics in humankind, and I'm sure we'll follow the overall trend in that we will eventually get through this. But even though for us 2 years plus is a very long time, for the virus, it may not be the time course. It may take a little bit longer or a lot longer, and we'll just have to wait and see, unfortunately. But we're learning to live with it, aren't we? And it's one step at a time as a community, and supporting each other in avenues like this, in organizations like the LFA, and in your own communities and families. So don't stop doing that. I bring this up because there's this thing about ivermectin in terms of stopping progression to severe COVID, and that's been shown through randomized clinical trial not to be true. And these things quickly get sort of a life of their own. Remember when hydroxychloroquine or Plaquenil was in short supply very early in the pandemic, because people were really freaking out, and understandably so, but not having anything to combat this. We did not have vaccines then, but it was totally unproven. And until you go through the time to do these very critical double-blind placebo-controlled trials, you don't know. And ivermectin got into the public consciousness, especially in certain groups. And it's a dangerous drug in some ways, and it doesn't work against COVID. So I did want to take this time to have a particular theme about talking about treatments for COVID if you were to get infected or have a breakthrough infection, kind of what people were using ivermectin for. And thankfully, in addition to the vaccines to prevent getting infection, or vaccines to minimize the severity of an infection once you got it, we actually have some treatments now available for people once they get infected. So these are outpatient treatments. These are not ones to be given in the hospital setting, but for those that are at high risk for having potentially severe outcomes, including people with lupus and those with severe symptoms as an outpatient, we have these options available. We have sotrovimab, which is a monoclonal antibody. You get it as an outpatient intravenous infusion that's given once. Paxlovir, which is a combination of these two medications that you take orally for 5 days. You have Lagevrio, which is an oral medication for 5 days. Remdesivir, which you may remember was available before, and it's still around. It's not as effective in the Omicron variant, which is why it's not as mentioned as often, and plus we have these other new medications above. But when it is available, it has been used, and it's an IV infusion as an outpatient for 3 days, each day for 3 days. And this is a brand new one, Beptelovimab. Beptelovimab. So very tricky names, I see, but you can read it. It's a one-time infusion, and it's only a 30-second infusion. And that's the latest one, I think, in the past couple of weeks. The problem with these things is that they're very limited supply. And thankfully the cases are going down, which will give us a reprieve, and God forbid, but if we were to get another spike, hopefully the manufacturing and these drugs will work for the next wave that is to come, and we'll be in a better situation to have better treatments for those that have breakthrough and otherwise, infections, symptomatic infections, especially in high-risk groups like those of us who live with lupus or care for someone with lupus. Now at Emory, just a couple of weeks ago, we only received 60 doses of this medication up here, and across one of the largest health systems in the state. How do you dispense that? I'm sure it's gotten better since then, but it gives you the sense of the magnitude of how little access we had to these drugs, and why you probably haven't heard much about these. Paxlovid and Lagevrio were only sent to some retail pharmacies. And just to share with you, my parents got COVID a couple of weeks ago. My mother, who has lupus, she actually ended up doing fairly well. She only had moderate symptoms for a few days, but my father, who's about 8 years older, didn't have other comorbidities like lupus, but obviously his age. He was very frail, and this really took him over. Almost sent him to the hospital. He ended up doing well, or better. I mean, he's about 95%, but it was really touch and go. And even for me, I couldn't get these drugs. I remember looking online, and these medications were maybe in a couple pharmacies in South Georgia, and there was just no way that I was going to be able to get them myself. But the point is that these will get better, the access will get better, but those who have significant risk factors, including having lupus, will continue to be prioritized because you're severely immunosuppressed, and vaccination may not be fully effective. They are effective, but not fully effective, or as effective as what we want them to be in an ideal situation. And then certainly for those who are unvaccinated that have other high risk factors like increasing age, or even slightly younger age, but you have multiple comorbidities, or if you have a BMI or body mass index that puts you in the obese category, those are really high risk individuals. So you can go back to the recording for some of these slides. I'm going to go kind of quickly through each one of these drugs just to give you a sense of what they are. They're going to change over time. They're going to be new ones. And even for us physicians, it's hard to keep track of. But you can go back to the recording and look at this in more detail if that's what you want. But this drug here is sold under this brand name, and it's a human neutralizing monoclonal antibody. So it's what your body would naturally make to fight off an infection that you already had, but they are able to manufacture the monoclonal antibody against the virus that causes COVID and infuse that. And the other thing I mentioned is that I didn't mention is that these drugs have not fully gone through the approval process, but have gone through enough processes before to show effectiveness and relative safety, and that given the urgent need for public health, that they qualified under the Emergency Use Authorization, or EUA label, which is what the vaccines were basically under until fairly recently. So we're kind of used to this process now. It's important that we get things out that show a good signal. And so this drug here, sotrovimab, are again for people that are oxygenating okay, but you know, when you start getting into the lower 90s, it gets a little touch and go. But who are not hospitalized, over 12 years of age, that weighs at least 88 pounds. And the more recently you have had the virus, the better these things will happen. So that's the other key, basically with any medication for almost any condition, but especially in infectious disease, if you're using drugs like this, the earlier the better. And so even though it's indicated for those up to 10 days of having symptoms, the study showed that the best effect is really in the first 5 days. And so having any of these high-risk conditions, including lupus again, and having symptomatic COVID infections, especially in the first 5 days, this would be a drug that you could consider. There is a sort of rationale, a way to categorize people so that we prioritize who gets access to this very limited supply of medications. Hopefully that'll change, but until the supply really meets the potential demand, we're going to have ways to categorize people. And so the first tier, the ones that should get medications first, they're put into this tier 1 highest risk sort of group. And that includes those that are severely immunocompromised, who are not likely to have responded to vaccination. And so this is people with lupus that are on a lot of the medications that we use for lupus, especially, I mean, I think almost any medication that you use for lupus can qualify to be put into this category. But the clearest ones are going to be those that affect B cells, including rituximab and possibly belimumab or Benlysta, and higher doses of prednisone, meaning if you're on 20 milligrams a day or higher, those are certainly the clearest, highest risk. But I think almost everybody with lupus would fit into this group. And then you can see the other categories here, which probably also include a lot of people with lupus having these conditions of the heart and the lungs and the kidneys that so many people with lupus have. And then you can see the intermediate risk. And this is a more complete list that I just have here. For those who are interested in looking at some of the details, you can go back. You can see the high dose of steroids or prednisone, corticosteroids greater than or equal to 20 milligrams a day, biologic agents, and this is just to remind you that these are infusions of monoclonal antibodies, and we've heard stories of people getting caught off guard and thinking that they would get something different and showing up to the infusion center and before the IV gets put in, being really shocked at that. So just keep in mind that many of these are IV medications, but not all. Paxlovir is the other medication. It's an oral drug that blocks COVID virus replication by blocking one of the enzymes. It's for those 12 and older that weigh at least 88 pounds that have a positive infection with COVID within 5 days of symptom onset, and at least one risk factor for severe disease, which includes having lupus. The thing with this drug is that there are a combination of medications. One of the medicines helps keep the other medicine, that really active medicine, at higher concentrations in the body. It keeps the body from degrading it as quickly. And this ritonavir is also used in HIV medications to accomplish the same thing. This is not an HIV drug, but ritonavir, we do have experience with that because we do use that in HIV medications to do the same thing, basically to keep the concentration of the other component of the HIV medication high in the body so that it can do what it needs to do better. And so this is the same drug, ritonavir, is used in Paxlovid, and it has a lot of drugs that it potentially interacts with. And so you need to talk to your doctor carefully, make sure that you're not in any of these. And there are websites that can help you kind of locate whether there may be a facility near you that has availability of this drug. Lagevrio is also an oral drug. It forces errors in the virus replication, so it's not able to successfully replicate. It's indicated for only adults, so a little bit older, mild to moderate COVID symptoms within 5 days, at risk for progression of severe disease, including lupus. It's not really the first one that most people go to. You have to be careful that you don't give it to someone who may be pregnant or at risk of being pregnant because of potential side effects on the fetus. And you can go to this website to see if there's any local places available. And then this drug, the one that I had trouble pronouncing, bebtelovimab, is the latest one that got approved by an EUA from the FDA. And this was just a little over a week ago. And it's again treatment for mild to moderate COVID-19 in adults and in those that are 12 years of age and older, weighing at least 88 pounds, with a positive COVID test who was symptomatic in the early week or so, at high risk of progressing to severe COVID-19, including those with lupus. So this is great. I remember early on when vaccines, we were praying for them, they were possibly on the horizon. And here we are, we have at least a couple different vaccines. People have gotten several courses of them. They are effective. We're learning better how to use them. Unfortunately, we're needing boosters, but they're providing good efficacy. And here we have a set of medications for those that even if they do get infected and they become symptomatic, we're able to have a good chance of minimizing the severity of the infection as an outpatient. Now, this next drug here is a different drug. It's called Everyshield. It's for preventing COVID. Everything that I've talked about earlier is treating COVID as an outpatient to keep it from getting more severe in those at high risk. This one, Everyshield, is a monoclonal antibody that's used to be given to people that are either vaccinated but are so immunocompromised that they won't mount a sufficient response, or for those who are not able to get vaccinated, for the very rare situation where they've had a known reaction to an ingredient in the current COVID vaccines, which, by the way, is different from the ones in the flu vaccine and the other vaccines. So just because you've had a reaction to those doesn't mean that you will get. In fact, there have been some good studies to show that the COVID vaccine does not overlap with the flu shot in terms of those types of allergic reactions. But in any case, there are some people that can't get the vaccine for legitimate reasons, or who are just so immunocompromised. There are medications like rituximab, which would really blunt the response of a vaccine if you were to get the vaccine during the 6 months that you're covered with the rituximab. And this at Emory, we had very few cases, but we had, doses relative to the many who would potentially qualify. And so we've had to put people into different tiers and kind of make decisions. But again, over time, access to medications like this will get better. It's going to transition to some questions here. This is someone who echoes a story that happens a lot. You get friends and family, well-meaning, who just really is against getting the vaccine, and honestly trying to protect their family members because they really believe that it's not safe, especially for someone with lupus. And this person was able to get the first one, did relatively well, but the second one was associated with a flare that unfortunately took her into the hospital and took a lot longer to recover. So what do I recommend for those who haven't gotten the vaccine? And would you recommend it for all patients or certain patients depending on their symptoms? The general recommendation, which I support, is that everybody with lupus should get vaccinated. I know a lot of people will have different views of that and choose not to, and I respect that. But the data out there is pretty clear as a whole. Again, I'm not talking to one person or this person in particular, but generally speaking, the fear of the vaccines having a high risk of triggering very severe lupus flares needs to continue to be looked at. But there have been several studies, and it's not been shown to be consistently or significantly associated with very severe flares. There's always some exceptions out there, but given the frequency of these infections, the chance of poor outcomes, not even the chance, the number of people who have done poorly with lupus, with a COVID infection that have led them to go into the hospital and to deal with severe issues from the virus, not the vaccine. You always have to weigh that against the vaccine itself. And unfortunately, in this case, you think that the vaccine caused it. And I don't know any other details. I can't argue otherwise. But I can tell you that the risk of getting severe outcomes from the COVID infection, the chances are much greater than that of getting a severe reaction from the vaccine. What I also remind people too is that it is normal to get a reaction after the vaccine. You talk to people that don't have lupus, including myself. I've told stories in the past where I got kind of sick after, especially my second COVID vaccine. And I had to stay out of work for a day. I think it was a day or two, but it goes away. And with lupus, you should expect the same thing. But having lupus, as you know from previous infections, previous stressors, you're just not able to recover as quickly. So having a reaction after the vaccine is not necessarily a flare. It's more probable that it was a reaction from the vaccine, a known one, that's triggering your immune system to learn how to fight COVID. And we expect that in a lot of people. It's just that having lupus may make that reaction feel a lot worse, and it'll be longer for you to recover from that. And thankfully, this story here on this slide is not common in people with lupus. The reaction to the shot is, and that's common in general, not just people in lupus. But after a couple of days, a few days at the most, you get a full recovery, and you have significant protection against poor outcomes from a COVID vaccine. So I recommend either Pfizer or Moderna in any series, in any order, and without any hesitations. Regardless of the type of lupus you have. And there's some caveats with the medications like rituximab that I mentioned before. And you need to talk this over with your doctor, who knows you the best. But generally speaking, I have not had any hesitation to recommend that generally. This is a question about the home COVID tests, these testing kits, and a story that's out there about how parts of the reagents or the chemicals in those tests, if they were to become frozen, become less accurate. And so the concern is that some of these tests, when they're being shipped, may have been in cold environments, and your results may not be as accurate. I'm not an expert in this area. I've not heard much about it, so I can't really comment. And all I can say is that, thankfully the weather is getting warmer. And so if you do think that you have bad batch for whatever reason, you could either get a new batch at the store, or if you're really concerned about the accuracy, you get a PCR test. And that requires that the results won't come back for a day or two, but it's come back pretty quickly from what I've heard, and in my own personal experience. That given how everything's some more routine regarding testing, including PCR and the number of places that you can get it, you should be able to get a test result back within a day in general. This is a request to talk about long COVID and its association with autoantibodies like that found in lupus. I was going to actually speak about this next month. So I am going to ask, this is a teaser, and I don't mean to cause any anxiety by not talking about this now, but I do want to address this question about panicking a bit. I will tell you right now that the risk of long haul COVID is not having autoantibodies from lupus, because that's what lupus is you have autoantibodies like ANA and anti-DNA. Just because you have lupus that produces autoantibodies and you get COVID, you're at high risk of long haul COVID. It's actually the opposite. The long haul COVID in people that do not have lupus seems to produce in some autoantibodies. And in fact, I think this story, and I mentioned this very early on in the pandemic when the first stories came out about long COVID, I think this is showing us possibly a window as to what may be going on in that we've known about for a long time, all of us here, about what happens in lupus. Lupus, you have this immune response, and you have these autoantibodies. You can treat some of the inflammation. The lab tests become normal and the exam becomes normal, but you don't feel normal. You have these symptoms, and what you're hearing about in the general population is a reflection possibly of what is going on in lupus. And so at the end, it may finally give us a way of shedding light on the impact of lupus and these long lupus syndromes, is what I'm going to call it. The things that don't seem to be treated by our lupus medications that people have suffered for so long. But we'll go into that a little bit more next month. But I wanted this person not to necessarily panic. Just because you have lupus doesn't mean you're at higher risk of long haul COVID. But that doesn't mean that you're necessarily protected either. We're still learning about this, like everything else. So I don't want to lessen the importance of this question. It is a very interesting question of whether, if you have lupus, if you have these symptoms from lupus, does having COVID make it worse? So I'm not saying that that's not an important question, and that may be an issue, but I want you to know that just because you have lupus and you have autoantibodies, that doesn't mean that you're at higher risk that we know of having long haul COVID. You may not. What the stories are telling us is that people that don't have autoantibodies before, without lupus, when they get COVID, they develop autoantibodies just like lupus, many of them, and they're having these long haul symptoms. So but we'll go into it a little bit more next month. And this is kind of what I was going to present as well anyway, next month, that all of this speaks to this, these other impacts of the pandemic. I mean, we will, for the time being, and rightfully so, continue to focus on vaccine and treatments in acute infections. But we're at the point of the pandemic where we're starting to sense the long haul issues, not just long haul COVID in terms of the symptoms, but there have been reports of increased heart disease risk of having COVID over time. So I think we're just scratching the surface as to the potential issues that are more midterm and long-term away from the active infection. So we need to continue to remain informed and to educate each other and to teach each other and to support each other. Because hopefully when the acute infection part of this starts to subside more and more, we'll have to deal more with the long-term effects. So thank you again for spending your evening like you graciously have done and shared with us throughout the pandemic. Keep going to trusted sources, including the LFA-GA website here and the resources, and not just COVID, but everything that has to do with lupus that's important to us. The National LFA also has good resources. And continue to send your questions to info@lfaga.org. Now, next month, I'm sorry to throw out another wrinkle, but I'm not going to be available the second Sunday. So the next meeting will be March 20th. And I look forward to seeing you then, if not sooner, and continue to stay safe, everybody, and keep supporting each other if you've done, and supporting me. I really appreciate that. Thank you. Have a good evening.